Good afternoon, everybody. So in the interest of time, I'm going to get started. Thanks for coming to the session. So just to make sure you're in the right place, the session's Didactic Academic Health System Administration as an Avenue for Career Development, how to forge a pathway in administration, how you can forge a pathway in administration. Just so you know, this didactic was developed by the SAEM Faculty Development Committee. Jeff Siegelman's here, who's the chair of that committee. We spent the past year developing this, so a lot of thanks to him and the support of the Faculty Development Committee, and also to the SAM staff, which includes Hollybird Duncan, Andrea Ray, as well as Kat Nagasawa. So thanks to them and to the program committee as well. Thank you so much for coming here this afternoon to spend time. We have a great didactic here for you today. So we have all these wonderful panelists, experts from across the country. So just to name who they are, we have Dr. John DeAngelo, who's the Senior Vice President and Executive Director of the Emergency Medicine Service Line for Northwell Health. So he oversees the operations of 17 emergency departments. Next to Dr. DeAngelo, we have Dr. James Adams. He's the Senior Vice President and also the CMO of Northwestern Medicine, as well as Professor and Chair of Emergency Medicine for the Northwestern Feinberg School of Medicine. Next to Dr. Adams, we have Dr. Lewis Nelson, who's the Professor and Chair of Emergency Medicine at the Rutgers School of Medicine in New Jersey. He's also the Chief of Service of the Emergency Department at Rutgers University Hospital. Next to Dr. Nelson, we have Dr. Patti Adelman. She brings a very unique perspective. She's the Vice President of the Center for Learning and Innovation at Northwell Health in New York, Long Island, and is also the Director of the Physician Leadership Development Program. And then last but not least, we have Dr. Nicole Franks, who's the Chief Quality Officer for Emory University Hospital, Midtown, and an Associate Professor of Emergency Medicine at Emory School of Medicine. So thank you so much, everybody, for joining us. Just a little bit about myself. My name is Nancy Kwon. I'm one of the Associate Chairs of Emergency Medicine at Long Island Jewish Medical Center, which is part of Northwell Health as well. So thank you so much, and I'll be moderating this session. With regards to financial disclosures, nobody has any financial disclosures. And just to review the goals and objectives, it's to provide an interactive, and I mean interactive, so I really want all of you to get involved and ask our expert panelists questions on how to forge a pathway towards healthcare administration by hearing from some of our leaders and their experiences and pathways. And to describe the different roles in healthcare administration. So all of our panelists have actually had multiple different roles in healthcare administration and have much experience in all these different roles. And to identify the qualities needed to achieve success in healthcare administration so they can give you their personal perspective. And Patti Adelman also has a unique perspective in having some data as to what works in leadership, what personality traits. And last but not least, to learn about how administrative fellowships and leadership programs can assist in developing a pathway towards healthcare administration and leadership. So without further ado, those are our mug shots, just in case you forget who we are. I'm going to actually ask each of the panelists to introduce themselves and spend a few minutes each talking about their journey towards leadership in healthcare administration. So I'm going to go from Dr. DeAngelo this way.
We were asked to use these things. They're recording. How's everybody doing? So my name is John DeAngelo. Currently, as Nancy had stated, I'm the executive director in charge of a large network of about 17 emergency departments, 5 tertiaries in that mix, 1 freestanding ED. And in addition, I oversee an operation that's now at 45 urgent care centers on a march towards 60 to 80 over the next few years, and a big EMS operation, an emergency management arm of our organization as well. My path was not a traditional path, was not through, it was basically more through community emergency medicine, where I was the director of several sites throughout my career. And then within Northwell had taken leadership roles in several big system-wide projects, the biggest of which was our health system's sepsis effort back in 2009, and a big, basically across the network drive to reduce our system-wide mortality by reduce it by more than 50%. which we achieved and received the Eisenberg Award from CMS a year or two ago for our success in sepsis. And I think it was through the involvement in a lot of these projects, as well as doing a good job running emergency departments along the way, I was asked to kind of lead the operation for the system.
So I'm Jim Adams. I'm currently the Chair of Emergency Medicine at Northwestern and the Health Systems Chief Medical Officer. As that System Chief Medical Officer, I have 8 Chief Medical Officers reporting to me, Clinical Informatics, GME, Research, and the Medical Staff Offices. And I still remain as Chair, which everybody says is stupid, and it is stupid. So I don't know that I'm a good advisor here. But to briefly, very briefly, talk about the journey, I went to Georgetown Medical School, University of Pittsburgh Emergency Medicine. University of Pittsburgh in 1988 because I wanted an academic career, and there were not many academic universities that had emergency medicine. The Air Force paid for Georgetown Medical School, so after Pittsburgh, went to Wilford Hall Medical Center in San Antonio, Texas, when it was the big worldwide referral center for the Air Force. Arriving there, you realize you didn't get paid more for doing more work in the military. I mean, back in 1992, when I was in the Air Force, I got paid $65,000 a year, no matter how much or how little you worked. Everybody's trying to get out of work. I kind of grew up on a farm in Pennsylvania, and I just kind of, I'm a worker. So I took on the quality safety stuff, which was emerging. 2 years in, the typical Air Force, a lot of leadership turnover. 2 years in, the 2-star general needed to appoint a new chair because the chair had left. And I knew all the data. I was hosting the Pentagon, Department of Defense, the congressional staffers who would come visit this center. And so he named me chair over senior officers. So the first lesson is, yeah, saying yes to stuff was a learning opportunity for me, but it gave me the visibility. The second point was I quickly realized the job was not just running the emergency department. My job really was to make sure my 2-star general got his 3rd star. And once I realized that, okay, so I was to make him look good and keep the emergency department running to make him look good. Left the Air Force, went up to Boston when the Harvard teaching hospitals wanted to put in emergency medicine. Was a vice chair at the Brigham with Ron Wells, who had just recently arrived. We put emergency medicine into the Harvard teaching hospitals, rebuilt physical plan, policy and procedure, faculty, and then a residency, and loved it there. I thought I was going to be in Boston. Northwestern came calling, said, "You're vice chair there, why don't you, we need an upgrade, come be professor." Took the division to departmental status, became a principal in the faculty practice plan. Faculty practice plan had a very difficult relationship with the hospital. I was telling people earlier, we chose Epic as our outpatient EMR, and the hospital chose Cerner as their EMP. And that's how much we cooperated. Did not cooperate, fought. But I'm like not a fighter, I'm kind of a cooperator, and in the emergency medicine kind of had success at Northwestern, head of the finance committee, the faculty practice plan, and when we finally did accomplish the integration in 2013, I became the health systems chief medical officer. Again, the CEO trusted me, the chairs trusted me, the dean trusted me, so that reservoir of trust plus competence, just like in the military, just like in Boston, that reservoir of trust plus competence was very important and continues to sustain. So in brief, that's the journey.
Good afternoon. So I'm Lewis Nelson. I'm the chair of emergency medicine at Rutgers, New Jersey Medical School, which is in Newark. And I actually did come to this role through a pretty traditional way. You know, in sort of the world of academic medicine, you probably recognize that there are kind of 3 traditional silos that people come up through, and that's either going to be clinical operations, education, or research. And I sort of came up through the education role, or the scholarship role. After my residency, I did my fellowship in medical toxicology, and I became program director shortly thereafter and spent a lot of my time working to develop my fellows and other junior faculty who were affiliated with my program. And I was very happy doing that job, in fact. But I realized that, like Jim had a realization at some point of how to sort of make your impact. My decision came about 10 years ago when I realized, despite the advice I'd given to other people, that you really have to find something that you enjoy and make it your own and develop a degree of expertise and credibility in that. And many of you, I realize, have done that already. But whether you come up through an operational or research or an education role, you really have to find something that you enjoy and really parlay that into what you view as an academic career. So I got very involved, obviously, in the toxicology world. I got very involved with drugs of abuse and sort of the opioid epidemic as it was developing. And through that and a lot of networking and other things I was able to do, I was able to sort of create for myself a really, sort of nice background, which I was able to use to sell myself as a prospective chair. Because my background came up through that one silo, I didn't have a lot of background in clinical operations, but you learn quickly when you start doing that, and you learn to delegate things that you don't know how to do very well. So when I say I'm in a traditional role, I'm at a single academic medical center. I'm not at a network or a health system. I have a medical school, a hospital. We have all the accoutrements that go along with that, but it really provides for me a really compact job that is very sort of easy to understand compared to what a lot of the other folks here are going to describe to you. Thanks.
Sure. Hi, I'm Nicole Franks. Right now, I am the Chief Quality Officer at one of the hospitals in the Emory Healthcare System. I came out of residency in 2002 with a goal of being a hospital leader and had no idea what that meant or who I wanted to be in that type of relationship. So I was very intentional about going through the traditional route to leadership, which is, aspiring to be a medical director. I will say I was very lucky to have great mentorship, and I often tell people I did a bootleg fellowship in a sense that I was working as a full-time faculty member, but still managed to find the time to learn and shadow and even be assigned projects in order to develop. And so in that regard, I made the first short list, and in my first job as an assistant medical director, I was basically told that was my job, which was okay with me because that's what I was there for. During the time of the mid-2000s when the quality journey was increasing across the country, Emory was being very intentional about developing their Office of Quality and the journey that they wanted to take the health system in. And as a result, there was a lot of resources that came to the healthcare system, and I was in a position where I got to be trained and found a great niche in process improvement and enjoyed it. Began to develop not only projects within the emergency department, but also projects with results, which is very important, and that is notable. During that time, also, I had a pretty broad reach of participation, not only in the hospital, in various committees, but also at the system level. So when the Chief Quality Officer moved on from my hospital, I again made another short list because of the breadth and depth of the things that I was doing at that time. So some of the words that you're hearing as the mic has been passed down around visibility, around delivering, those are very important in your preparation. And that's why I'm standing here today. And the things that I really enjoy about quality and patient safety, process improvement, and another part of my job is risk management, is really the coaching I do. I sign no checks. I don't manage a budget. I've had the luxury, well, I don't know if it's a luxury, but it's an opportunity to manage people directly, but that when I took the job, I had no direct reports. But over the course, I've had various numbers of direct reports, most of who have been as a result of process improvement projects that required resources to address some particular objective. And so I was trusted in bringing on these people. So again, there's lots of things that I've learned along the way, and I will tell you my bootleg fellowship helped me. At the time in 2002, there wasn't many programs around. Now there's plenty with lots of physician executive mentors. And so we'll talk a little bit more about that as we move into the rest of the time.
Good afternoon, everyone. So I'm Patti Adelman. Unlike the other individuals either sitting in the audience or sitting up here, my way to healthcare leadership came a little bit different because I am not a physician, so I did not go to medical school. Actually, my entree into healthcare was as a clinical social worker. I started actually at NYU getting my master's in clinical social work and was assigned to a hospital in Manhattan where I worked with pediatrics and loved it. And that was my entree into healthcare. I actually came out to Northwell Health as a clinical social worker. And I think I was there about 2 weeks before our director said that she was resigning. and we would have 2 weeks before there was no director. And I was the only one in the department who had some supervisory experience, and so I put my name in the ring, so to speak, and went to speak to our executive director and said, until you find somebody, I'm certainly willing to supervise the department. Bingo. Probably about 6 weeks later, I was told I actually had the job and Joint Commission was coming in a matter of months, and good luck. So that was my entree into healthcare leadership, certainly from the clinical perspective. I was there for 8.5 years before transferring over to our corporate university, where I took my knowledge and skills that I had developed both as a social worker for about 7.5 years and a director for 8 years, and brought that to a more macro level where I was teaching leadership development. You've heard other people talk about the fact that you sometimes are called upon or sometimes you volunteer yourself. But our organization was really wanting to have physicians take a bigger role in decision-making processes, but recognized potentially that there was a gap between their skill sets, what they had learned, and what we were going to be asking them to do. And so I was asked to please take a role in not only doing leadership development for our managerial team members, including nursing, but looking at it for our clinicians. That was back in 2010, and we sort of birthed a full Physician Leadership Institute, which offers probably over 120,000 hours worth of education for our physicians, from residency all the way up to our senior executives on a yearly basis. So one of the things that I would like to add, in addition to all the words of wisdom that you heard here, is I think that it's really important to love your job and find your passion. I think that ekes out in a way that other people can see really easily. I'm very lucky to be able to say that I come to work every day and love my job. When people ask me, what do you do? It kind of reminds me of when I started in social work in peds. Everybody said, oh, you work in peds, it's really hard. How hard is it? It must be to see kids who are really sick. And then when I tell them that I work with physicians, they say, oh, that's really hard. You work with physicians? So I feel like my career has sort of come full circle. But, you know, I really love what I do, and when that aha moment happens and I can see somebody transformed in the way they think or the way they behave, it certainly is a joy of my own. One of the other things that I think is really important is, as you leap into a leadership role, whether it's academic, educational, research, or clinical, is that you really start to need to switch your mindset from leading yourself to helping to lead others. And it is a different mindset from, you know, thinking more centrally in the self to thinking about your team, whether it's a team of, you know, 2 people or a team of 200 people, looking out for their interest and their development.
Thank you so much. So I do want to open up the questions to the audience, but I do want to start on one topic with Dr. Adelman. And that has to do with what is a corporate university, what is the Center for Learning and Innovation, and what sort of metrics have you seen at the program?
Thank you. If you don't mind moving one slide,
Sure.
that would be great. So many large organizations in healthcare, but traditionally in for-profit businesses, GE, McDonald's, Disney, JetBlue, have a university that sits inside their corporation, and the idea is to create a learning opportunity within the organization, so that individuals may not have to seek supplemental education externally, either from other businesses or other universities. Northwell Health started their corporate university in 2001. We started in a very small space that probably had about 6,000 square feet, and have grown into a space that has over 55,000 square feet. We are not just leadership development. The Center for Learning and Innovation has a simulation lab that has over 10 rooms that can run concurrent simulations with mannequins, as well as debrief rooms. We have everything from a mother-baby simulation, adults, pediatrics. We also have a clinical skill center that looks an awful lot like the Step 2 CSE. And we use that for clinical interventions with our medical students, our graduate nursing students, our PA students, as well as attendings and our leadership development program, so that we have individuals interact with standardized persons, and those are individuals who take on the persona of a particular case. You may be familiar with standardized patients, but when we're doing leadership development, it's often not the patient that we're interacting with. It's either a more junior team member or managing up, and so we have them take on that role as well. Northwell Health provides probably over 350,000 learner hours within our corporate university on a yearly basis, in all shapes, forms, and sizes. So it's really interesting because one of the things that we've really learned over the course of probably the last 8 years in working in our Physician Leadership Institute is that certainly healthcare as a whole is changing, and there are 10 key leadership skill sets that physicians should have as they approach into leaders. There has been some research done by Teresa Koenig, an MD, who actually has done a lot of research on this as well. And she defines those 10 characteristics as collaboration and cooperation, and appreciation for other individuals, good listening skills, good communication skills, both oral and written, self-confidence and mental resilience, or grit if you use a very common word these days, humility, a lack of arrogance, the ability to mentor, have that work-life balance, and be able to create a vision for the future. I don't know about you, but in my working with probably over 800 physicians since the Physician Leadership Institute was created, these are skills that most people tell me they did not learn in medical school, that they did not learn in residency, and as they were developing themselves as clinicians, that it was not reinforced there either. So for the most part, these are skill sets that most people have within, that they're not brand new. We're not teaching physicians how to listen or how to be humble, but we are sort of shaping that stone or shining the diamond, so to speak, from a leadership perspective. And so when we actually do 360s for our physicians, these similar skills tend to fall to the bottom of those 360 assessments. So it's nice to know that for us and Dr. Koenig, who did the initial research back in 2012, that we're finding some very similar things. It would be interesting to see as medical schools do start to incorporate communication and empathy training within their environment, whether this list changes at all in a couple of years.
Thank you, Patty. So I just wanted to get some feedback from the rest of our panelists, physician leaders, and their thoughts of these qualities that are needed to be a physician leader. Your opinions?
I'll start us off. I think there's a common theme between what Patty was just quoting and what the rest of the panelists kind of said in their introduction. I think, today's leader needs to not just be a great clinician. It needs to be someone who's collaborative, who knows how to work with others. And I think a theme I heard very clearly amongst people's pathways, it's about getting involved and not just showing up, taking ownership of deliverables, delivering on those tasks. And that's what gets the attention of leaders above you when they think of someone to task future responsibilities with. And I think we don't get all the training we need through a traditional, medical school training. And I think, for me at least, a part of the journey was also grabbing onto the right mentors. So in my first site director chair role, the CFO was my best friend because I really needed to understand the budget process and my monthly P&Ls and my revenue cycle type of management. So it's not necessarily your traditional mentors. You need to seek those as well, but you really need to latch on to people, and you really need to be able to identify your personal gaps and address them.
That list is incredibly important. I think the most important thing, what I would observe is, as an emergency physician, you have this broad field of view, and I would really affirm the importance of those skills. However, the mental models that we build as emergency physicians do not translate into management. In emergency medicine, we go in, we talk to the patient, we formulate a diagnostic and therapeutic plan, and the tests get done. That's a command and control model. You might be very nice, it's a command and control model. Doing it gently, it's still a command and control model. If you walk into an administrative meeting and you do that same thing, the diagnostics and here's what we need to do, you read as a physician. The administrators stop and say, well, let's understand the problem. Well, let's define this problem. Well, tell me more about that problem. And so we start to prioritize, and we start to get the context and the sharpness and good agreement of the problem, and then we get a plan, we're on the plan, and we execute. That's what administrators do. So that listening is pulling out from other people their understanding of the problem, their definition of the problem, getting their head in the same space, and that's the consensus building. And then we can get a plan, and then we can execute the plan. It's a very different skill set, and if you walk in and start talking, you can tell they're physicians. So that's my view. The second thing is in the finance. If I talk to physicians, say, how big is the health system? They say it's 7 hospitals and 2 practice groups. If I talk to the business people, they say it's a $5 billion corporation, right? So how we talk about things, it's not right or wrong, but we read as physicians or administrators. So understanding some of that, don't pretend that we're going to be as good as finance, but pulling that out and listening and learning about it and understanding that language is very important. So operational implementation, define the problem, get a plan, execute the plan. Different than the emergency physician command and control because there's a team there. And then some of the financial language. If we cultivate that, you'll be absorbed very quickly into management.
That's an impressive analysis. Yeah, I don't think I could do justice to that. My take on this is, of course, those are important. There's many, many adjectives that we need to have affiliated with ourselves and our reputation and our interpersonal interactions. But I do think that we probably have to be very careful to avoid a lot of the landmines that we tend to walk into, particularly looking like it's all about us, and it's not about the people that work with us and about the system and about the patients. And it's a very fine line between a lot of these things. And some have used this term of emotional intelligence, perhaps, to try to allow you to take the pulse and the temperature of the people that you're dealing with. It does take a thoughtful approach to being a leader. I mean, every interaction you have to have, there has to be sort of an internal dialogue going on with every word that comes out of your mouth as to what it's going to sound like to the other person and how they're going to perceive it. And it's getting harder and harder in the society today to really parse your words in such a way that you don't step on your own toes or put your foot in your mouth. So I think it is all of these things are clearly right, but you really do have to intellectualize so much of what you do. What seems to come naturally sometimes is really very, unnatural.
So what I'll comment on beyond the characteristics of a leader are maybe some of the more tangible tools that you really need to develop. And I sort of think of it as communication, mediation, negotiation, and persuasion. And I think as an emergency physicians, we have that. We do it with an individual patient, but it's a much different arena when you're doing it with other administrators who have various backgrounds and perspectives on whatever the issue is at hand. So communication, understanding and being very clear and intentional about what you're saying. I will say mediation, you may be in positions where you're mediating perspectives. And I think we uniquely as emergency physicians are comfortable in that space, as well as negotiation. Here's my expectations of you, patient. Patient tells us their expectations, and we have to meet them in the middle. And last but not least is persuasion. Often this is where the consensus and collaboration is really important. You need to be able to help people understand how whatever the issue is important to them, how it translates to their bottom line. And if you can do those things successfully, I think that just elevates you as a leader as well. So those are not things that anyone ever told me, or it's sort of you figure it out along the way. Some of you may know you're talented in one or two or maybe all four of them, but you really need to exercise them and understand when it's happening and really be able to leverage them to be able to get things done.
Great, thank you. So I see a lot of young audience members here, a lot of young physicians. I want to see some people at the microphone asking our panelists some questions. Don't be shy. So as you saw, one of the some of the qualities include collaboration and cooperation. That's why we come to SAEM, in order to create bonds and collaborations with people from other institutions. So this is the time to come up and ask questions. Don't be shy.
Hi, thank you to all of the panelists. I am curious, when you were all describing your journeys, it didn't sound like at least most of you have obtained MBAs. And I was wondering, is that something that you think would have been useful, or would you suggest that physicians looking to go into administration might go and get their MBAs? Have you seen it to have been a hindrance if you haven't had gotten an MBA?
Also, can you tell us your name and where you're from?
Sorry, Alyssa Perkins, Boston Medical Center.
I think you should do it if you like it. It gives some frameworks. It'll get you an interview, but really people are chosen because they can deliver. They're chosen because they can deliver. Out of the senior executives who report to me, all the chief medical officers, clinical informatics, and others, only one has an MBA, and it's an insignificant issue. But all day, every day, MD MBAs come up to me and say, how do I get a role? How do I get a role? How do I get a role? All day, every day. So the majority of MBAs do not have management positions. The majority of the physicians in management don't, but having that MBA gives you that financial framework I was talking about, a problem-solving framework. You'll frame a problem. It gives you skills. Doesn't prove you can use them.
Hey, Judd Hollander from Jefferson. I have a very specific question, if this ever happened to any of you, where you are charged with doing a project that you know is in the best interest of the enterprise, and there's a roadblock, which is a human being somewhere along the line on your group who has, let's just say, has equal influence to you, and logical arguments don't work. Can you give me your strategies to getting done what you were asked to get done without obviously knocking this guy over?
Hypothetically, of course.
That's a great question.
So I'm not going to address, let them as a clinician certainly address that specific issue. But, you know, I think you're bringing up a really good point, which is that the street credibility, sometimes as a clinician, even as a wonderful clinician, sometimes only gets you so far. And depending on where that roadblock is, sometimes that roadblock is within your own department. So it might be another emergency room physician. Maybe that individual is an OB or a cardiologist. And so your technical expertise does not necessarily work to influence them. And so there's a whole other skill set, you know, or you need to have influence without the power, meaning you don't necessarily have the authority to just tell them, well, it doesn't matter what you say, we're going to do it anyway, right? And so it is a very different skill set that one needs to develop. I'll certainly see what this group, I'm sure they've come across it at least once probably in their career.
Yeah.
Hypothetically, of course.
I think this is part of the art of leadership, and it depends on, you know, I think the approach sometimes depends on who the person is and what their role is and what department they're in, and are they someone you report to, someone that reports to you. But at the end of the day, I think it's kind of what distinguishes, I think, leadership from management, and that is how do you motivate or inspire or convince people. And I think it's always best to bring it around what's, in my mind, regardless of the topic, what's the right thing to do for the patient? How do you bring the conversation there? Come to agreement on that. And I think it's almost like a negotiation skill. And if you can win those folks over who are typically obstacles, it makes the implementation and the sustainability a lot better than just avoiding them. And then every now and then, it's just when you can't come to ahead, then that's what chains of command and other avenues are for.
So I'm going to assume that this person, you try to exercise all the collaborative skills and the this skill. I'm going to assume that all those things have been exhausted. For the junior people in the room, there are kind of personal engagement and stuff that you have to go through. But I'm going to assume that that stuff's not working. Because, Judd, you're one of the people who I think is the best leaders in this specialty and, frankly, in the industry of healthcare today. So thanks for attending. It's intimidating to have you here. And there's a lot of very spectacular leaders in this room, right? So people that I really learn from and look to learn from every day. And in that vein, when I was this young chair in the Air Force, we were having bitter fights with trauma surgery over the emergency medicine residents' ability to run traumas, right? Remember those days. It was a peer, it was a lot like that, and this person had no incentive to give, was not going to give, was not going to help us. And so we, with the DIO of the organization, have a lot of ugly meetings, and all the other department chairs were there. And after one of those meetings where I was getting nowhere, the chair of medicine walked out and put his hand on my shoulder. To this day, I use this technique. He put his hand on my shoulder. He said, you're never going to topple the wall by punching it. Line up all your strong backs and slowly, steadily push. And he walked away. This old grizzled colonel, right? This Vietnam era guy, right? I had no idea what the hell he was talking about. But I thought about it, and I thought, really, this is important. It's about training. It's about military preparedness. So I went to the chair of pediatrics. I explained. He's passionately on my side. Chair of anesthesia. He got it. I needed it for training. It wasn't ego. It wasn't power. It was training. And all the chairs, next meeting came in, I didn't say a word. All the other chairs forced this guy, and the wall tumbled. And so I would say, if the person's on the team, what other strong backs can I cultivate? How can I give them wins? How can I move this forward? And so that's my technique ever since when we were up in Boston trying to build EM, line up all my strong backs, and walls would tumble. But that's the only thing that I have to offer. All I can say is I use it every day.
Yeah. That's the building the constituency method and works often. The other thing is finding the right messenger, because sometimes you might not be the right messenger, and maybe it just takes a different person that they listen to that says exactly what you said, and they're ready to listen to them. So that's another tactic that can be used as well. I'll offer that.
My only thought to add is that my approach to these things is usually just sort of a high road approach, and it does mimic what a lot of the other folks have said, which is if you believe in what you're doing and you take the high road, inevitably it will work out. The end point might not be what you think the end point should be, because it's never really your game. I mean, it's multiple people playing in all of these things, and there's lots of perspectives on it, but not everything that we do is meant to go our way as we see it. So you take the high road, you allow things to happen, and they work out the way they work out. And that might be a little philosophical for some people, because we do often feel like we have to be the victor, but I don't think it always works out that way. So we just have to be a little, accepting sometimes of the fact that we're not the only person in the decision-making pool.
And I would just add one other thing. I know certainly working in a large organization, in some places they say location is everything, and I find that timing is everything. And there are definitely some times where we're trying to make change, and it's not necessarily just the person, but you say something on Monday, and for whatever reason that is not well received, and you take the high road 2 weeks, you say the same exact thing in the next meeting, and everybody thinks it was the best thing, since sliced bread. I didn't say anything different. It's not a different audience. It's not even a different messenger, but there just may be something slightly different happening in the environment around you that allows somebody potentially to be a little bit more receptive to whatever change it is that you're trying to drive.
And I don't want to drag this on, I just wanted to put one more thing out there, the line up all the strong back, slowly, steadily push. That's, I believe in that, but the other mantra that I use is know your enemy better than they know themselves. And so, for example, in my world, I want to get a lot of stuff done, but the CIO is just not there, won't show up to meetings, just not there. But in that process of discovery, the CIO didn't hate me and wasn't avoiding. He was scared. He was overwhelmed. He's hit by all quarters. And so I moved around him to start to organize the work, start to prioritize the work, start to control the flow of information to the work. And then he became a little happier, and all these other people were like, well, I'd very much appreciate an organized conversation because IT is a mess. And so it gave them a safe, prioritized thing to execute, and then we could get our stuff in line, not as fast as we wanted, but created a safe spot for them to be successful. So when I understood the problem and their limits, I could help them be successful. And that has worked in my organization, where I found a similar barrier, a person that wasn't really opposing me, but just couldn't cooperate. So those would be some of the things that I'd have to say.
Thank you so much. So I would love to hear some more questions from our faculty members here in the audience, junior and senior. Dr. Hollander and Dr. Becker are welcome to ask questions as well. And please state your name and where you're from.
Hi, I'm Lorna Breen from Columbia University in New York. And this is terrific. Thank you so much for being here. The question I have has to do a little bit with collaboration and a little bit with improving your visibility in the hospital. As a leader at Columbia, I've signed up for many, many committees that I've realized after the fact are a complete and utter total waste of my time, that go on week after week, month after, for years. Or it's a committee where they're trying to accomplish something that's truly against my department and my patients. And I can't collaborate because what they're doing I just wholeheartedly don't believe in. And so what I find myself doing is not wanting to sign up for any more committees because I'm afraid it's going to be a dead end or something where they're doing something that's anti-ER. Can any of you give wisdom about how you pick, without the input of a mentor, because I know that's going to be some of the answers, without a wise mentor who says, do this committee but not that committee, how do you decide where to jump in and how to get out? Or where and when to jump in and where and when to get out?
So in 1963, after the Bay of Pigs disaster, the Congress formed a committee to debrief, and clearly it didn't need a committee. It just needed sunshine, and that the formation of the committee was editorialized in the New York Times. And the New York Times editorial, my favorite quote of all times, defined the committee as a group of the unwilling chosen from the incompetent to do the unnecessary. And I love that. I do not have committees. We just don't do committees. We can do it. We have objectives, we have goals, and we're executing goals. So if you could reformat the whole thing of what's the goals of Columbia, what's the problem, what are we going to fix, how are we going to advance goals, committees should go away. And you should have goals, and you should be executing toward goals. You should have a plan, work the plan. Have a plan, work the plan. And so when you have a committee, show up. Say, thank you very much. I'm not allowed to show up anymore because at SAEM, my first task was, what are we going to accomplish? I'm not allowed to go to a meeting unless we have accomplished something. And if it's an ongoing thing, then we have to have a goal, and we have to have a plan, and we have to work the plan. And if we don't have a goal and don't have a plan, I'm not going to work the plan, don't show up.
But it's not likely you're going to change Columbia. I mean, it's a great concept, and when you're the new CEO, you'll right. No, but we do live in the reality of the fact that we have committees that are do nothing committees. Your quote is exactly right. I mean, that's exactly what committees are. But you think of the alternative to your not being there, right? The emergency department would have no representation, right? So even though it may not do what you want it to do, without you there, it's going to do exactly what you don't want it to do with no oversight or no input from you. So again, it's the same answer. It's like we live in the real world and not everything's going to go our way. We have to be part of the solution, right? Because otherwise we're the problem. So I don't think you have a choice. You have to go, you have to do it, you have to suck it up. You got to complain about it. You know, you can do whatever you want, but you got to go.
I was just going to offer, when you're in some of those positions where you may not necessarily be tapped to be in charge, how do you position yourself to own something to push an agenda item and make the committee more active? Because the fact of the matter is running a committee is a skill, just like running a meeting. And I find often committees that don't work is because the people in charge don't know how to do it. And the mantra of get a plan, work the plan seems very simplistic and straightforward, but you're not surprised how many people that can't do that. And so if you're willing, and you sit on these committees, if you're willing, maybe do less committees and be more active on fewer committees and step up. And maybe that might give you an opportunity to exercise those skills and actually leave with deliverables that you can speak to as to what did you do in your time on that committee.
Thank you, Dr. Breen. That's a great question. Just out of curiosity, what is your role at Columbia? I'm a medical director. You're the medical director there. Thank you so much for coming. Dr. DeAngelo, did you have anything?
I'm going to reiterate a lot of the same stuff. We'll go to the next question.
Okay. So, audience members?
Once again, guys, thank you very much for being here. My name is Tim Murphy. I'm a third-year resident in Cincinnati. And many of you mentioned the importance of good mentors. And you mentioned that you seem to stumble across good mentors. I'm going to give you guys a little more credit than that and say it's probably not just luck that you stumbled across these people. How would you recommend finding good mentors, and then how would you approach them and then nurture that relationship?
So I think maybe the first step in finding a good mentor is deciding who or what do you want to be, and then who is doing that. And so once you have figured that out, if you are in a position to figure that out, when you approach that person, be prepared to help them understand what it is that you want to achieve and what you expect them to help you with. It really is always a return on investment negotiation. I found that my successful mentorship relationships have been because I asked for something, they gave back, they put me in positions to do things, I delivered. It was a back and forth. So he made his 2-star general become a 3-star general. That's what your mentor wants too. And so it's a back and forth. But it all starts with probably understanding what you want to be, who's doing that, and then approaching that person or other persons that way. You can have different mentors that have a different thing about them that you want to achieve or learn about, and that's okay too. I think it's a gold mine if you find someone and you say, I want to be Dr. such and such. So I'm going to go talk to him and I'm going to figure out, or her, how can I be them? What are they doing? Go watch them, go shadow, go sit in their meetings, just listen and see how they got there.
I would just add, I understand that you're a third-year resident, and so you're still amassing, your clinical knowledge. But I would just say that in addition to looking for somebody who you appreciate for what it is that they do, I find that an extremely important role of a mentor is not only to be able to watch what they do and learn from them, but a mentor should be somebody who gives you the opportunity to implement what you're seeing and learning. And so the person can't be too selfish in the sense that they might be willing to say, come to a meeting and kind of watch what I do or see how I do this, or here's my rationale for why I did this clinically or this administratively, but gives you the opportunity to try it out in even a small setting. So amongst your peers in residency or, in a larger forum. And I was going to actually kind of bring this up to you. I think that that's an important role of a mentor, is sometimes to put the person's name out there for opportunities so that hopefully it shouldn't be you just seeking them independently and, traveling down a very deep rabbit hole, but that hopefully somebody who is your mentor is looking at your skill sets and looking for opportunities to utilize your strengths as well as to help you grow in the areas of opportunity.
My one just piece of practical advice is that mentors are people too. And that's where you have to use that EQ we talked about before and think about what people want. And there's this old expression, it probably comes from the business world, which is, if you ask for money, you get advice. And if you ask for advice, you get money. So, don't go guns blaring telling this person what you want them to do for you, but sort of ask them for advice. And that will build a relationship a lot more quickly than coming in with demands, even looking like you're looking for something from them.
So with regard to mentorship, I have a question. So Patti has been one of the directors of the Physician Leadership Program, but that's a multidisciplinary program. So I know Dr. Franks and Dr. DeAngelo have clinical leadership development programs for administrative fellowships for emergency medicine. Can you sort of describe how those work and what value they have and how the individuals are mentored and what outcomes you've seen out of those programs?
So the model at Emory has been essentially to put a fellow in a position where they're functioning as a leader within a leadership team, and they get mentored by the director at a particular hospital, as well as the entire administrative faculty who have niche experiences and interests that they offer the fellows. And so our fellows do have the opportunity for continued graduate medical education, learning, whether that's MPH or MBA if they so choose. But what is emphasized is niche development, the projects that they take on, whether that's scholarly and or quality, and delivering. And so what our goal is for our fellowship is they come out fully exposed to what it is to be a leader in an emergency department and can take the role of an assistant medical director at minimum, if not a medical director at the appropriately sized facility. And we've been pretty successful with that. I would say right now we have about 50%, maybe a little bit more. I didn't do the math before I came, of our fellows who are at least in assistant medical director roles, if not a medical director role.
Yeah, so our fellowship, we have certain fellowships at a couple of our tertiaries that are specific to that site. What we went and developed at a service line level is an administrative fellowship that's a year long. It starts with exactly that. What is the area of interest, the track these people are more interested in? And then throughout the year, we put them on 3 or 4 month rotations where if their interest is more emergency management and EMS, they'll work with that arm of the operation. If it's more clinical operations, I have a clinical ops team that uses improvement science, works with sites on operational efficiencies. They'll work with that team. They may spend a month or 2 with me in a senior leadership type of role. But it's finding throughout the 8 or 9 different areas I can expose them to that are system-wide or system-oriented, they get that exposure. In addition, we created a year-long didactic leadership development program specifically in emergency medicine. We have about 20 folks a year that go through training on all the various, tools of leadership. Some taught by our system experts in strategy, finance, that nature, and some taught by emergency medicine folks with the niche expertise that's worth bringing to that group. And then we also tie them to a specific project through the year, whether it's a new ED we're designing and building and going into, whether it's a quality initiative or some sort of task force. But I think having a project that caters to their expertise, not their expertise, their interest and their long-term path is a critical part of the fellowship.
I'm not sure if Dr. Adams or Dr. Nelson have experienced administrative fellowships at your programs.
So we have, and I think it's about starting on a lifelong career journey. So we'll move on to the next question because I thought that was answered very well.
Okay, perfect. I'd like to hear some more questions from the audience, and please introduce yourself.
Hi, my name is Ren. I'm one of the interns from Beaumont Health. I just had a question. I'm starting out, from the very beginning when you guys are coming from emergency medicine side, academic side, going on to this more of a systemic role, tackling problems outside this, the circle of competence. How do you, what's your strategies, personal strategies for developing competence or gathering a plan quickly so that you can deliver on these projects that you may be unfamiliar with because you haven't been exposed at this point? Yeah.
The most underutilized skill by emergency physicians is asking for advice. And people in healthcare love to nurture and give advice and advise and guide, wildly underutilized. And so you ask questions, you deliver, you shape it up, and pretty soon they're thinking you're competent because you're listening to them, right? And they think you're brilliant. So really, it's just, as you've heard before, really delivering and putting good thought into it, but then getting lots of feedback, advice, and guidance, and opening yourself to that.
I would just add, there are lots of resources out there, a lot of them free, to expose yourself to when those situations arise, or as you anticipate potentially what might I need to know in order to excel in this particular area that I've never been exposed to before. Some of your organizations, even if you don't have a corporate university, may have, you know, an area which attends to CME that's not clinical but brings in leadership or finance education. Your organization may partner with a university that, you know, offers some tuition remediation, you know, in order to have their physicians participate and gain new skills. Online, believe it or not, more and more, there are resources out there that are good resources out there. Coursera, for one, you can take a Harvard course, a course from Penn, MIT, you know, there's lots of great opportunities out there. You just got to stick with it. You know, usually they're a couple of weeks long, but they're great opportunities to continue on that journey of lifelong development, learning and development.
Run out of time.
Is there another session here afterwards? Yes. Oh, okay. So unfortunately, there have been so many great questions. Thanks so much for joining us. I think the panelists will probably stick around for a few minutes afterwards if you want to ask them questions directly. So thank you so much for coming to this didactic. We appreciate it.